Okay, so at this point, we move into our question and answer with the speakers, and we are essentially right on time. We wanted to move to this at 1:45, so thank you all of your speakers for your well-timed comments. And so I'd first like to invite committee members to turn on their cameras and microphones to ask their questions. Is anyone really willing to start? I see Aravinda has his hand up. So Aravinda, please go ahead with the first question.
So first, my thanks to you, John, and to all for, really terrific talks and speakers. So I just want to make a comment because this has to do with the work of the committee that makes it perhaps more useful and challenging at the same time. And I want your answers to sort of reflect that. I always say that human genetics is not on the same scale as bacterial genetics, worm genetics, fly genetics, going up to human genetics. Human genetics has a different quality, which is why I think Aiken's talk sort of mentioned many aspects that we have to underline the human part, as well as many of the practical questions that both Gil as well as Nancy covered. And a way out, I think that Graham just pointed out. But I wanted to ask sort of a conceptual question of Gil. Gil, you spoke about genetics or genes or genotypes perhaps changing a baseline risk. And I'm just wondering if you would help me think through that. I think since we are born with our genes, I would think that that's the baseline. So does it matter which one you put on top of? So shouldn't we have a genetic baseline risk and figure out environments that change it, which clearly in some applications appears to be?
Thanks, Aravinda. So it's a good catch, absolutely, and clearly the truth is more complicated than sort of the sense in which there's a baseline and your genetics modulates you up and down. There is a interplay between your genes and your environment, which kicks off from the day, well, probably before the day you were born. The reason I represent it that way is because clinical practice is reasonably used to working with the idea of clinical risk modeling, and it's widely used in various areas of medicine today. So in terms of getting clinical factors recognized as, or getting the introduction of genetic factors operationalized and accepted by clinicians, then thinking about genetics as modulating that baseline is it's a somewhat cartoony version, but it's a helpful concept in terms of that acceptability. And one of the really valuable consequences of thinking about it like that and representing it like that is that it doesn't require a sort of a total rewriting of clinical practice. It's not like saying, forget everything you knew, genetics, it's all genetics, and then other stuff has to come in. It's like everything else you knew, but we're going to introduce a new risk factor. It's like the other risk factors that you measure, but what we're going to do is to bring that risk factor into the world in which you're already working, and to think about how that would modify your thinking about the individual in front of you. So fundamentally, I totally agree with you, Aravinda. It's a cartoon version of the world, but from an operationalization and an acceptability point of view, it's a way that we find is helpful when communicating these ideas.
Great. Thanks, Gil, for that clarification. Molly, I saw you had your hand up. Oh, it went back down. Are you okay? Give me a nod if you...
No, I saw Dorothy has a question, so I'll go after her. Sorry.
Okay, great. Dorothy, please.
Okay, thank you very much for those insightful comments. I have a quick quick question, I think, for each speaker, if that's okay. And I think we're using full first names, so forgive me if that's not appropriate, but that's what I heard. So Gil, you spoke about using various population descriptors because they were important for context. And the descriptors you use, sometimes you put them together: sex, race/ethnicity, genetic ancestry, even nationality, as descriptors that were important for context. Those seem like very different kinds of descriptors. Nationality, for example, clearly not a biological category. Genetic ancestry, more of a biological category. I'm not sure where you would put race/ethnicity, although you said these are about how individuals perceive themselves. And so I just wondered if the context you're talking about is a social context, and whether these descriptors are all social descriptors, or just how you define what that context is, because it seems to me that whether we see the context as a biological risk or whether we see it as a social environment that has some relationship to the risk, the genetic risk that you're calculating, would be important. Akiyemi, I hope I'm pronouncing your name correctly. I have a question about your point that it would be important to notify a particular ethnic group or racial ethnic group. You mentioned Native Hawaiians in your example, about their risk for the safety or efficacy of a drug. And I wanted to ask you about a concern I have that we might see as the opposite concern, which is the major public health failure of denying people care because of automatic decisions made based on race. For example, a recent study finding that tens of thousands of Black Americans have been denied placement on a kidney transplant waiting list because of automatic decisions about a glomerular filtration rate or their risk of kidney disease based simply about their race. And I would be concerned, for example, about getting advice about whether I should take a particular drug, whether it was going to be safe or efficacious for me based on my race. So what is your response about the harms of making decisions about the safety or efficacy of any medical treatment based on race? And I also wondered about your views of genetic diversity within racial groups. So I thought you were advocating for including racial categories as a way of diversifying research and treatment, but what about genetic diversity within racial groups? Nancy.
So, Dorothy, how about we, I want to take all your questions, but why don't, for the sake of our processing power, we take those two first and responses, and then we'll,
all right.
then we'll hear the next.
Okay,
great.
Thank you.
Okay, great. Gil, go ahead.
Sorry, I'll try and give a brief answer. So that's clearly a really good question, Dorothy. What I think the way I think about these things is that many of the things that we measure about an individual are indirectly correlated with the things that really matter, the causal things that, if you could modulate them, would actually reduce your risk of a disease or to make you better if you were sick. And so many of these things that we measure have an element of social construct to them, but if they have an impact, it is pointing, if there is a correlation, it's typically pointing at something that's real. And it's the job of science to work out what that thing that's real is. So you said geography is a sort of a social thing, but actually it can be a very biological thing. You know, people living in Finland have a a different exposure to UV from people living in Spain, for example. So, there are biologically relevant differences which correlate with geography, and it's a really important, and trying to understand whether is it UV or exposure to some pathogen or the diet or whatever, that's the important factor, is part of what we as a group of scientists seek to pursue. And I think you can argue that to some extent for everything that we measure on individuals. Stop there.
Great.
Thank you.
I can go next and answer the questions from Dorothy. So thank you for those questions. So the Hawaiian example that I brought up was not about not giving an entire population or depriving an entire population of clopidogrel. Really, the genetic variation, the variation in CYP2C19, which is the enzyme that metabolizes clopidogrel, which is a prodrug, into its active compound so that it can actually work. That is based on, so the efficacy of clopidogrel is based on CYP2C19 variation, not on race, and so I wasn't at all advocating for that. But I do see your point in terms of there's use of race and there's the misuse of race. And you brought up some points with kidney disease, et cetera, in terms of and transplant, in terms of the misuse of race. So I guess my answer to that is that I agree that we need to address that issue. I think the best way to do so is through education. We have to educate our medical students, our professional, our pharmacy students on the proper way to practice in a manner that's not stereotyping. But at the same time, again, you see harm goes both ways. If you avoid the descriptor, or if you avoid that issue, what ends up happening automatically is that I've never seen a situation where you ignore population descriptors and then everyone takes what's happening in a population of Black individuals and extrapolates that to everyone else. It's always the other way. It's always those who are self-identify as white. That's kind of always what happens. And so we kind of have to avoid that too. The racism goes both ways, regardless of whether you use descriptors or not. And in terms of, I think that actually gets to my point in terms of your question about genetic diversity within race. So again, within the population of Native Hawaiian patients, again, CYP2C19 variation is what ultimately impacts clopidogrel response. And in fact, when we do our studies, and even if we stratify by race, ethnicity, we still adjust for the PC covariates. So we actually do account for genetic diversity in race. I think that's very important. Local ancestry, and so there's means to do that. Thanks.
Okay, thank you. Well, that leads very much to my question for Nancy, because you're pointing out that what is important is the genetic variant that is, that determines the safety or efficacy of the drug. And I was going to ask Nancy, with your example about Duffy homozygosity being so critical, and that why not test for that instead of making assumptions, right, about who would have it based on their race? And then you said it's not about race. So I'm assuming that's your conclusion. Oh, you're muted. You're muted.
Absolutely my conclusion. And the conclusion in the papers that have been published on this, it's easy to test for Duffy. And so it's crazy. I mean, literally crazy that we haven't been doing that, given the profound impact on neutrophil counts, white cell counts, and so forth, on which many clinical decisions are made. And it's not that people have never heard of benign ethnic neutropenia. They have. Physicians know about it, but perhaps the litigious nature of our society in the US plays a role, but um, but they're not always practicing as if they do know and fully understand these things. And I will also note, Duffy is an easy example to pick on because it has a relatively large effect on a number of laboratory values. But the heritability of white cell counts in populations of recent African ancestries is quite high, and almost certainly reflects also some polygenic adaptations to local environments. And there's a polygenic version of this same thing. It is about the alleles and the genetic contributions to what we measure as white cell counts or neutrophil counts. And physicians are by and large shocked at the number of laboratory values that are heritable and at how heritable they can be when they are thought of so widely by physicians as dynamic measures of disease risk and progression. And I think, we have opportunities now to do a much better job with laboratory values as genetics come into medicine, because many of these laboratory values would be better markers of disease risk and progression if we regress out all the genetics and let physicians focus on that dynamic part of the range.
Thanks. Okay, I had one last question for Graham. Is that how you say your name? Thanks for a really enlightening presentation, which is a little ironic because I think that many people are turning to genetic ancestry group as a way of ending the use of race as a population descriptor. And of course, ancestry is a better way of describing someone, some aspect of their genetics than race, which is a social grouping. So I think the idea that ancestry is, a substitute for race, should not be equivalent, is why ancestry, one of the reasons genetic ancestry group is becoming more popular. But you have pointed out a lot of problems with it, including, I'm so glad to hear someone say that there is this unspoken bracketing of a specific time, some point in human history when these populations emerged, and that time is never stated. Of course, if we go back all the way to the beginning of human history, we are all related, and we're all related to Africans. But at any rate, I'm wondering though, in your talk in distinguishing between genetic ancestry group, which you're encouraging us not to use, and genetic similarity or genetic relatedness, if the problem is population, if it's the groupiness of it, or groupedness of what we're trying to do, that's an issue. And if that's the case, should we not, should our mission not be population descriptors? I'm just having trouble wrapping my head around how to get away from the individualized nature of what you're recommending, because it seems like you're focusing on how an individual is genetically similar to another individual as opposed to the group level, and what those implications would be if we follow your direction for even talking about population descriptors. In other words, how would we talk about a population descriptor in terms of genetic similarity rather than group?
Yeah, so thanks for that. So as I say, I think there's different things happening here, right? So there is social categories such as race, And there's this move towards using genetic ancestry as being a better proxy for the underlying genetics and moving away from using race as a label for genetics. I think the fundamental issue that we face and you face in talking about the the descriptors, right, is that we need somewhat discrete terms that verbally can be communicated to each other. And genetic ancestry does seem to be that, where we could talk about the ancestry of an individual. But as I say, that comes with a series of problems. And I'd argue that most of those could actually not be sidestepped, but avoided by talking about what we mean, which is genetic similarity. By how we use that in terms of a population descriptor for an individual or a set of individuals, is we could talk about which group of samples in a predefined set we are more similar to, right? For example, I fall closer to individuals who've been already labeled as Northwestern European genetically. And so I could be said to be more genetically similar to those individuals. And indeed, that's a good descriptor of me. Obviously, there's a discreteness there to how we boil down that label, right? But I'd argue that in the continuum of relatedness of individuals, it's always going to be, there's going to be some discreteness, and we need our labels to be accurate to get across the point that there is some reference samples that are being used, and it is our similarity to those reference samples which is defining our concept of genetic similarity, which this concept of genetic ancestry is a proxy for. So I agree it's difficult. All of these terms are imperfect, right? All of them are going to get loaded with various things as soon as we start using them. But I think that genetic ancestry, while closer to the genetics than race, comes with a sequence of problems that we don't actually need most geneticists to be grappling with. We need geneticists to be grappling with social labels. We need them to be grappling with differences amongst individuals, but we don't need to create such strong linkages between the two.
Thank you.
All right, Molly.
So I have a question that I guess could be answered by a number of different speakers. A number of speakers sort of mentioned race and ethnicity labels, basically, or context, as Gil phrased it, basically as proxies for what I interpreted to be unknown environmental effects that might interact with genetic effects in ways that are relevant to diagnosis, clinical care, and so forth. And so if that is indeed the reason that they should be used, then I'm wondering sort of what's the level of resolution at which we should use these things a priori? How do we know if it should be racial labels or ethnic labels, and what degree of, so how fine-grained should they be, and what kinds of sort of, how do we avoid making assumptions about, if we don't know what the environmental factors are, how do you sort of conceive of defining that context, and how do you imagine we could move forward to sort of transcend the use of these labels? What kinds of other data might we think of collecting that would allow us eventually in the sort of future to sidestep those decisions?
Should I have a first go and then others can chip in?
Go ahead.
So I think if you clearly, I think I mentioned this in the talk, I would welcome sort of multiple levels of granularity, and individuals being not categorized, having identifiers from the very broadest to the very finest. And the only way we're ever going to make progress on trying to work out whether, what this thing is actually capturing is by measuring more stuff. So you need to measure more stuff about how people identify themselves, and you measure more stuff about lifestyle and environment, diet, and so on. And at some point, you'll be able to see that the variation explained by the biological factors is sort of overwhelming what you see at the level of the socially constructed race and ethnicity labels. you may think that ultimately you are unlikely to capture everything, and there'll be some residual stuff going on. But I think I don't think that there's any one way of. I think saying there is only one way of doing this is a mistake, because it stops you from being able to learn about what actually is the true causal process.
Do others want to add to that point? That response from Gil?
So
Go ahead, Nancy.
and others may well want to as well, because I think from not just the health equity perspective, but certainly from the health equity perspective, there's a lot of, it's important to understand the health consequences of race as a social construct. And I don't mean of social deprivation, or I mean race. I mean the way people who are brown and black in America have life experiences that affect their health. And so for now, unfortunately, because I think there are health consequences to being black and brown in America, I want those labels so that we can collect enough data and use that information to improve health. And it's not that I disagree with what Gil says, but there are health consequences, and there is a long literature of social scientists using these same categories to try to understand health and life consequences of these labels. So I am, they need these labels for their research. We need these labels to try to undo some of the long-term and now some institutionalized disparities that are directly related to the labels. So I mean, for the short term, we will need some of these kinds of labels just to undo harms that have already been done.
I can add by saying simply, even if we don't have social labels and we have other ways to measure genetic variation and we find an association, that doesn't necessarily mean that the reason for that association is not due to social reasons, and vice versa. When we have differences between social groups, that doesn't mean that it's because of social reasons that there's a difference. So removing the label isn't necessarily going to, doesn't mean that if we remove the label, that doesn't mean that we're gonna, every single difference that we find is due to biological reasons. So I can just add on by saying that.
Great, thank you. I wanted to Graham, did you want to add anything?
Yeah, so I think the self-identified and social labels are proxies for a set of environments and the lived experience of people. Clearly, if we measure the environments more carefully, we could start to identify sort of social and biological causal factors instead of using the labels. It seems to me for now that, as others have highlighted, that the labels are, adding information on top of the environmental measures that we can possibly take. I think there's a real risk for us as geneticists, though, that those self-identified labels, those social labels, and those genetic labels such as genetic ancestry become absorbed into seeing biological differences and genetic differences between individuals. As geneticists, when we talk about, for example, genetic ancestry, it's very easy for us to slip into that being absorbed into genetic influences rather than being a part of the social environments. And so I think these labels are useful. They are a useful way of helping us think about how environments are potentially structured over individuals, but it does come with risks in how we use them in research and how we need to be much clearer about how they're being used and why they're being used.
Great. I wanted to piggyback on that in terms of it's sort of in relationship to Akanyemi's points about addressing unevenness and inequities, that with relationship to the fine scaleness or coarseness of the bins, it seems there's a pressure, I think, in underrepresented areas to do coarser binning because of the constraint of getting sample sizes up for those groups. So for instance, in those 23 categories that Akanyemi showed, there was one for African, and even that was a very small number. And that's obviously a very coarse grouping. So I wondered if maybe Gil, Akanyemi, and Nancy, maybe in your work, could you speak to the challenges of where binning is partly being done regarding a constraint of sample size and getting sample sizes up because these approaches require large sample sizes, or is that more misperception of mine? Is that something that one needs to be thinking about in this problem area? And maybe to put a finer point, does that drive some of the use of continental ancestry rather than finer scale labelings?
Yeah, no, I completely agree with that. I mean, like I showed in my slide, we have 14 participants that identify as Samoan. What can we possibly do with that? So that's kind of the reason why I stated that I don't think that addressing population descriptors can be done in a vacuum. If we're not going to address the lack of diversity in our biobanks and in our clinical research study populations, I don't know how we can kind of get to this stage where we have no categories and no binning. So yeah, I agree with your point.
I don't really have much to add. I think clinical practice absolutely relies on the idea of generalization. You learn something over here, you can apply it over there. And it's beholden on science to go out and measure and look for disparities in access or outcome. But you are fundamentally limited by sample size, and I strongly welcome efforts to increase representation from groups that traditionally haven't been the subject of research, and that should absolutely be a major part of the agenda. But fundamentally, sample sizes, it's better to do something that groups people together to be able to ask a question than to because you need that for statistical power, than it is to pretend you can't ask that question.
Mm-hmm. Great. Nancy, anything to add?
Not really. I think Graham made some comments, though, that a lot of this is done to create sort of the best possible designs for analysis with what data we have. And so in some sense, part of the fine binning within the European populations is largely because that's often the biggest sample of cases, and where the failure to adequately correct for population differentiation in that group will lead to inappropriate conclusions and misinterpretations of associations. So it's a complex problem in that, all of the rest of the data is in many ways even more diverse, but we have so much less of it that the truth is it's unlikely to lead us as astray as as the huge samples of Europeans that we're also analyzing at the same time. But the solution is to have much more diverse population genetic data that we can use in analysis.
Okay, we have about 6 minutes, so let's go quickly. Anne, please go ahead.
Yeah, thank you. So one thing that is really striking me in this conversation is that these questions about labels and their appropriate use also seems to me to depend a fair amount on what kinds of studies, what kinds of genetic research we're talking about, and especially in terms of the interface with policy, with the public, and so forth. But with that in mind, I wanted to ask a question of Graham. I very much appreciated, the clarity that you are bringing to this issue of our talking about genetic ancestry when really what we mean or what we're really looking at is genetic similarity. And I have a question for you about your suggestion about how we might label samples for many uses in genetic research that wouldn't require these sort of old ancestry labels. And you sort of give this example of, we might just say simply, this sample is genetically similar to sample X. So I'm wondering whether labeling samples simply by geographic coordinates, so not even the kinds of labels that might be geographic labels that we translate into race or ethnicity, but something as simple as coordinates of longitude and latitude for where things are collected, may be labeled, or if we think about imposing a kind of grid on the map, a kind of a standard grid, so that we might just simply label samples by the grid of their location or the coordinates of their location and the time at which they are collected. Would that be an alternative labeling system that would serve the purposes, at least for the comparison and control of samples that you mentioned?
I guess I'm not sure that it would be. And I think that, so first of all, the choice of where we placed grid points would obviously imply something about how we chose to weight the variation we had present. We're clearly not going to do it continuously across space. Is that by population density? Then if we choose high density locations, there are going to be people whose genetic ancestors have lived, sometimes very locally, sometimes in very distant locations. And so to apply a single geographic label in terms of a Latin long coordinate to those individuals, I think would also be hiding significant amounts of inhomogeneity in at least some sampling locations. I think that, there's interesting ideas about grid sampling. Certainly human genetics should be moving towards sort of more continuous sampling rather than sampling on the basis of identified groups necessarily. But I'm not sure that, labeling samples by grid coordinates isn't going to create a whole bunch more confusion, at least, among geneticists about what we're really talking about. If a coordinate falls in the UK, are we talking about people whose ancestors have lived in the UK for a long time, or who were sampled at that moment out of sampling? So that's my response on that.
Thank you.
Mark, you have a question?
Yeah, Nancy's, a couple of things that you said really struck me. One is that our current descriptors are not really calibrated to capture the diversity in the populations that are treated. And I think the follow-on was that the race ethnic descriptors that we're currently using are just, they're kind of a stepping stone, if you will. I'm taking that from your talk. But something that resonates when I think about the work that Gil does and the work that Academies does, and essentially if we're in this dynamic world where we have these dynamic relationships between the population descriptors and the social determinants of health, how should we move forward based on this kind of dynamic? Right now, Gil has examples of studies that were taking population descriptors from different countries and different time periods, that kind of thing. So I just wondered, should we be shackled to the old labels of the past, or as we move forward, how should we be thinking about these labels in a kind of more meaningful way?
And Nancy, I hate to do this, but we have about 1 minute. So
Yeah, no,
I'm sorry.
I think we've all learned, as Graham said, this is ways of verbal communication sometimes need translation, and we need to recognize these are dynamic relationships, and that may mean some dynamic aspects to the language we use to describe these relationships, and we will have to live with that and work with it and make sure that we are as clear as we can be about what we mean, and recognize that this is a dynamic landscape, always. Everything social is going to be dynamic, and we just have to live with it.
Thanks, Nancy. So it's time for us to close. I want to recognize that I wasn't able to get to several angles of this, but including some of the questions that came in. But I want to recognize that some of the questions that were coming from the audience. They're wondering from us about, how does one rationalize categorizing people into specific groups. I think a lot of the answers spoke to that, but some of the exact mechanics of that, of how one decides East Asian versus white, and the mechanics of making these study defined or ERH based groups. So that's the mechanics of that is something we didn't unpack. And then the questions emphasize too, the how all of this perpetuates the myth of races, which I think is something that we need to remember in these acts. So I just want to recognize those. I think several of the talks touched on that, but they were hoping we'd expand more. But this has been a very fruitful discussion. I'm very thankful to the speakers and the discussants and the audience. So thank you, everyone. And then let me see in terms of the next cue. For the break, I've lost my notes, but we will be coming back at 2:40 p.m. So thanks, everyone.